Well, I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research, and thank you for coming today. We have a very interesting talk by Maher set up today to talk on the electronic optometric medical record. This is a project in the School of Optometry, and I'm really looking forward to it. I'm not going to say too much about that because our good friend Dominic Covey is going to introduce our speaker and introduce the topic as well. I do have a couple of announcements, however, that I want you to be aware of. The first announcement is that we have two upcoming seminars that I think would be of interest to the audience. One is our Waterloo Smarter Health Seminar, which will be on November 23rd at 3 p.m. in DC 1302. Richard Alvarez, who is the President and CEO of Canada Health Infoway, will be coming. He'll be talking about their primary area of strategic development, and that is the electronic health record to be put across, I guess, all of Canada. So he'll be talking and giving us an update on that project, the development and implementation of that project. Canada Health Infoway, as you know, has received a lot of money from the federal government, I think to the tune of $1.5 billion. So it should be a talk of interest to every Canadian when you see that much public money going into a project of that size. The other talk that I want to mention to you is our next research seminar, which is on December 14th. So we hope to see everybody back for that talk on December 14th. Maher, do we have a speaker yet for that?
Not yet.
Not yet. So that will be announced very shortly. The last thing is that the Institute, the Waterloo Institute for Health Informatics Research, is going across campus, has been doing for a number of months now, giving talks on health informatics, what it is, and how people can get involved. And it's particularly directed to faculty, but as well to students, undergraduates and graduates, to get their understanding and interest in health informatics. Our next one will be in Environmental Studies on November 10th at 12:30, ES1 221. You're more than welcome to attend or encourage your students to attend. It probably will be good to get one in optometry. We did one last term, in the springtime, but we should be doing one again soon. So maybe I can talk to a couple of you about getting that organized or with Maher. Anyway, that's all I have to say. Dominic, will you introduce our speaker?
Well, welcome, Maher. Maher had the misfortune, or whatever you want to call it, of being one of my graduate students, and somehow managed to get through the whole thing and did a really interesting piece of work looking at software engineering related to procurement. It became clear that Maher had a real role to play here in optometry, and for a while he worked. For a while now, he's worked with optometry, putting together the school's electronic record. And this is critically important, that the school needs to capture its information. The information is valuable for research. Maher has taken that on and is doing it. And also it needs to measure itself against medical programs that have become the standard for care. And so we're introducing a lot of things into optometry that really didn't exist there before. At the records level with Maher, and Maher is also involved in a group along with Graham and others related to performance measurement within the School of Optometry in the clinic. So it's a very interesting environment, and Maher's work there is particularly challenging because there are a lot of people who are in optometry who are basically clinicians, and what you're doing is going in and interfering with their work. And Maher has taken a very studied and careful approach to doing with that. So I'm looking very much forward to hearing about your presentation today. Welcome.
Thanks. Good afternoon, everyone. The outline of my presentation today will cover the current situation of the paper record. I will give you the whole picture of the electronic health record and define the electronic optometric record in the School of Optometry and why is it today. I will also cover the fears, realities, challenges that are usually related to electronic medical record system. I will mention the guidelines for a successful implementation, and I will demonstrate some implementation plan, and finally, who will give you a demo of the system and we'll get some discussion. All of us in the School of Optometry or any other healthcare organization are aware of the paper record issue. File might not be found. We have patient coming today or this afternoon, but the file is not there. File may not signed out of the file room. It might go to different clinics after appointments without any tracking mechanism. And file usually handled and needed by various students, staff, faculty members, and might be needed by more than one person in the same time. Paper files usually come in various format and structure with different design and layout, and usually associated with the handwriting legibility issues, and they are very difficult to search and analyze data in a paper record. And also the issues of storage and retrieval of large number of paper files. The list can go on and on. So what is the alternative for the paper record? It is the electronic record. What is it? First, I'd like to define the electronic health record. And the name has been evolved over time from computer-based patient record to longitudinal health record to the electronic health record right now. It is defined as a repository of all healthcare-related information about individuals throughout their lifetime. And the information is accessible online through an electronic network. On the other hand, the electronic medical record system is concerned with the storage of one aspect of healthcare-related information in local systems, in clinic, in hospital, in home care, and so on. It is considered to be the building unit of the electronic health record. In our case, to be precise, for the School of Optometry, the system should be called the Electronic Optometric Medical Record System. This is just to give you an overview of the entire picture designed by Canada Health InfoA. On the lower level, we can see the local systems that are in local hospitals, clinics, pharmacy. And on the top level, we see the electronic health record repository, and the in-between, we see the communication bus where information go back and forth using the highest level of communication protocol, which is HL7. And in a recent article in June of 2005, mentioning that 3 nations embark on electronic health record voyage in Canada, United States, and Australia. In the United States, President Bush has outlined the plan to implement the system in 10 years, and it has been mandatory to have electronic medical record system in many states in the United States. In Canada, we have Canada Health InfoA that is in trust of billions of dollars to establish the electronic health record in Canada and release the technology architecture for this system. This is just to give you an overview of the activities done by Canada Health InfoA, that it oversees many information technology related to healthcare all over Canada and territory. This is also to give you an overview of the electronic health record architecture. As you can see here, the applications on the local level, and here is the repository of health record. And in between, the communication bus and the information go back and forth this way. And all these systems will be connected together through an electronic network. What is the current situation in healthcare organization in terms of health information technology? We are far behind when it comes to health information technology in healthcare compared to other industries like banking, insurance, airlines, and so on. We also underinvestment. It has been estimated in recent research that healthcare spend as little as 3% of its revenue in health information technology compared to other industries that is 10% in banking. In recent research, it's showing that about 100 to 200 people in the United States die every year due to potentially preventable errors. Many of these errors can be avoided by using information technology systems that are available right now. And millions of dollars waste every year due to the lack of information, repeating unneeded tests, ineffective procedures, and simple human errors. I would say that technology is not the issue. It is usually the process and people to implement information technology system in healthcare. Lately, it has been electronic medical record system decisions from the government that is supporting the implementation of electronic medical record system in terms of grants and incentives. Many academic and research institutions in Canada and United States have taken the decision to implement electronic medical record system. Also, private clinics in Canada and United States have already taken this decision. The School of Optometry in the University of Waterloo has envisioned the importance of the electronic medical record system a long time ago with its goal to be leader in, among academic centers and leader in research and teaching. What do we expect from the electronic optometric medical record? We expect that the system will improve the structure and accuracy of patient records, facilitate access to information, eliminate all the eligibility issue related to paper records, and eliminate the problem of misplacing or losing files. For researchers, they will be able to research real data, view and compare similar health-related health cases. In the overall, it will improve the healthcare delivery. As I mentioned earlier, that usually the system comes with some fears. People afraid to have electronic system. The first one, I would say that people say that the system will change the way we do our daily work. In reality, it will. It will change the way how people deal with the patient, how they deal with students, and how they deal with others. But the reality is that it is required that people leave their comfort zone and switch mode now from paper to electronic real-time mode. Some would say that the system will complicate our daily work or work environment. I would say in reality, are we happy with what we are doing right now on paper? By doing the current workflow analysis, we can see how many areas in the workflow or the work environment need to be improved. And the solution will be in the electronic medical record system. It will make the eye exam longer. Eventually, over time, when the person masters the system, the exam time will be very short. Some people would say that the system will affect the patient-doctor communication, affects the supervisor-student communication. In this regard, I would say there is positive and negative view. Some people will see it negatively, and some people will see it positively. On the negative side, or the pessimistic side, that people will say that it will worsen the communication, decrease our productivity, and affect our expertise. On the positive side, people will say that it will improve, increase productivity, extend our expertise. An optometrist in SUNY State College of Optometry in the United States have commented on this slide. He recently implemented electronic medical record system there, and he said that I have been using the system for a while now. To some extent, the system affects the communication, but I will never think about going back to paper. And he is advising his students, if you don't know how to use the electronic medical record system, don't come to my clinic. I would say the bottom line in this case would be how the system is implemented and how is it managed. We're expecting that the system will improve the communication. Students and supervisors can interact on computer screens through the instant messages. I would say, I give you an example for that the student might be in the first floor clinic seeing a patient. The supervisor might be in third floor in the same building or in a remote location, and can view the same information that is currently in use by the student. A student can interact with the supervisor instantly, ask questions, supervisor can provide advice, and in the same time. We also,
Doesn't that assume, though, that the information that the student is garnering is in a form that you can send by instant messaging? I mean, my experience in the clinic is that very often the student sees something, and it's not part of their familiarity, their experience, and so at the end of the examination, they bring in the supervisor in order to see it as well
Exactly.
and comment from their experience.
Yeah.
And it's not clear to me that those kinds of things can be passed through instant messaging.
The instant messages will be to ask question, to receive answer, but the supervisor and the clinician will have the same view of the system. He can open the system. I will show you in the demonstration how this can happen. They can see how far the student in the eye exam, how many information have been collected yet, how the eye exam is progressing with the student. He can see the information instantly, can see the same view that is I'm seeing right now in front of the patient. Instant messages just like talk instantly through the Microsoft messaging. They can talk instant messages. The student can ask question and get the answer right away. I will show you how this can happen in the demonstration at the end. Sure. We're expecting that patient book their appointments as well. They can see or view their health-related information and get reminder email about their appointments. The main challenges that are facing any electronic medical record implementation is that it will change some aspect of our daily work. As I mentioned earlier, yes, it will. And we have to be open to change and leave our comfort zone to establish the electronic medical record system. It will require all the users learn how to use new technology and get up to speed with the new technology. Some of the workflow will be changed and will be changed how we document our work. The main challenges that are facing the electronic medical record system, usually the end user, unrealistic requirements. They ask for more than the technology can get or can establish. The acceptance and resistance, it has been studied that 45 to 50% of systems fails due to the user resistance and the interference, although the systems are technologically sound. I would say that the most advanced tools are only useful if people use them. So now healthcare organization or the School of Optometry or any other clinic or hospital want to have a system. So they get into the dilemma which system to buy, which way to go. They go to trade shows, look at the systems, they get impressed with the colors, layout of the system, and they send requests for proposal, and they get response, yes, we do have what you're looking for. Is this the right answer? I would say with the technology, we need a methodology to establish this. In my master work, I did develop a framework for healthcare enterprise systems integration that I followed in my work. Before I go through the framework, I'd like to give you an overview of the current situation in a typical healthcare organization. Many healthcare organizations have a large number of information systems. This table here shows you the number of information technology systems that might be available in one healthcare organization. These systems are in different formats, have different data structures, different coding. Some of them, or many of them, bought off the shelf, and some of them may be built in-house. They don't talk to each other. There is overlapping and interdependencies among these systems. They live kind of isolated islands. And there is really a big need for tighter integration to integrate these systems and to have a sound procurement methodology. This is the current situation. Hospital E has information systems, and the other hospitals don't talk to each other. What needs to be done is on the organizational level, the systems has to be integrated together. And on the regional level, also the information has to be passed on from one place to the other. And also on the national and global level, the information has to be passed through the messaging exchange. And this is also on a very high level of the electronic health record, how it would look like. The health information technology framework that we developed, inspired by the main principles and techniques used in areas of software engineering, component-based software engineering architecture, and systems integration. We drove lessons from both classical approaches to systems integration and component-based software engineering, and we got our rules. We believe that the framework will benefit various stakeholders, software vendors, systems integrators, and in our case, we focus on the systems procurer, the healthcare organization, related to evaluating and selecting appropriate system. For end users, the clinician, the staff members, the students, related to understanding the implications of the requested changes and requirements. This is just a list of the rules of the framework. First, I would like to mention that defining, or rule number 1, define the overall systems requirement. By overall systems requirement, I mean that we want to build a system of systems, not only not building electronic medical record system. We need to build a big system where all the current system and the future systems will be integrated within one system. Then we define the overall architecture. Again, this is the overall architecture for the big picture. Select an architecture style, adapt existing systems within the architecture, define and document commercial off-the-shelf systems requirement. Here, I mean the system that we want to procure. In this case, will be the electronic optometric medical record system. Rule number 6, to incorporate all the criteria in a structural procurement technique. Rule number 7, to consider all the future systems that's going to be procured in the future and fit all the systems within the architecture. Before I go in details, I'd like to show you the typical software development life cycle in the waterfall, where the requirement defined in the beginning goes to the system design, implementation, testing, release, go to the end user. On the other hand, the procurement process is a different model where the requirement must be defined, then acquisition, acquire the system. In this stage, we identify the systems and select or evaluate the system, and finally we select them. Then we go back to system assembly and finally testing. These are the two different models, whether we build a system in-house or we procure it off the shelf. And which way to go? Would we buy the system or procure it off the shelf? I did a comparison on both ways and found that both ways have negatives and positives. To custom make the system in-house, it's concerned with the development of a large and complex systems. The negative that in this process that it will take long time to do. It takes up to years. And the cost would be very high, and we maintain the system. By maintaining the system, I mean that the cost or the maintenance cost of a system is about 70 to 80% of the total cost, which is very high in this case. The positive, the system will satisfy our need. The system is built for us, and we have control on the system. On the other hand, if we buy the system off the shelf, the negatives of this process is that it doesn't quite match our needs. The system is not built for us, so we have to accept what we get. And someone else has control on the system. Positives of this process is that it takes less time to get the system. The cost will be very, very low. We have a variety of choices to choose from, and the system is pre-selected, and someone will maintain it, which is reducing the cost again. Defining rule number 1, to define the overall enterprise systems architecture. It's a key activity in system engineering. We need to define the functional and non-functional requirement. In this case, I would like to give you what I mean by that. Is now we're looking for electronic medical record system, so I'd like to know what are the requirements. We're looking for imaging, digital imaging system in the future, maybe in 2 or 3 years, so we'd like to know what you're looking for. We need evaluation system, or we might need lab system. All the requirements must be defined early on a high-level basis. And we currently have patient management system. Also, we define the requirements. All the integration requirements must be addressed, and the overall needs and sources, data and inter-system communication standards must be defined. The requirement will go further beyond this issue to address information about vendor, technical ability, expertise, stability in the market, legal issues related to the procurement, terms, condition, contract negotiation. And as I mentioned before, that we need to define which of the existing systems can be used in the building as building units in the architecture, and which system can be either procured from the market or be built in-house. There are so many tools that we can use to establish these requirements. In our case, we used the traditional methods of requirement elicitation that will cover the interviewing customers and domain experts through the questionnaires and observations, and study the documentation of software systems. Rule number 2, to define the overall systems architecture. This is a central engineering activity in software development. It's similar to building a house. Professor Danbury in the School of Computer Science in the University of Waterloo wrote a paper, did the comparison between building a house or remodeling a house and software architecture, and showed the similarity between the two processes. Define the overall system architecture is always influenced by the architecture of the select systems, existing system that we already have in place, and the middleware and the standards. This picture just to give you an overview of what we are looking for. Define the overall system architecture that is affected by what we have. The architecture will also affected by the legacy systems that we have in place in the organization, the future systems that we're looking to procure, and the current system that are available in the market, and definitely with the big picture, the electronic health record. A good architecture is the one that supports business goals and fulfill the organizational requirements. Rule number 3, to select an architecture style. By architecture style, I mean it's a set of rules to identify the systems and connectors and how these systems will talk to each other. Example of architecture style is the layered architecture, pipe filter, client server, database, messaging. Each one of these architecture style has strengths and weaknesses, but there is no time actually to discuss this issue. We need to choose the appropriate architecture style that fits our need. Then we need to adapt the existing system within the architecture using the system integration techniques like wrapper, glue, system tailoring, mediators to fit the current system within our architecture. Here we need to define and document systems requirement. This would be, in our case, will be related to the electronic optometric medical record system. We need to address all the domain-specific needs and requirements. And also the requirement must extend beyond the system functionality to include system properties, constraints. And the requirement will be the base of the evaluation criteria that will be evaluating different systems based on. The requirement in the beginning will be described on a high level, and we can discriminate between systems in the early stage in the process. Then we need to incorporate all the criteria in a procurement technique. As I mentioned earlier, if we buy a system in random, that will result a collection of mismatched systems. Systems will not talk to each other. And to overcome this problem is a big challenge. Evaluating and selecting commercial off-the-shelf products as a key activity for the successful implementation and procurement. Rule number 7 is we should consider the future systems in the enterprise system architecture. As you know, that technology is going very fast. It changes every day. So we need to follow these standards like HL7 and buy extensible system. Select system with interface and avoid black box architecture. So we need to buy a system that can be integrated easily within our architecture and talk to the future systems. An example of the future system is the electronic health record. It's a key area of research in health informatics. And there are several organizations dealing with developing standards and protocols for the electronic health record. In Europe, in the United States, HL7 that developed the data exchange standard. In Canada, we have Canada Health Info that established the architecture for the electronic health record. So I'd like to give you kind of a quick diagrammatic view of the framework. In the beginning, we define the requirement, or we see the needs from the stakeholders. We need a system, digital system. We need electronic medical record system. Through the requirement engineering, we set the requirement specification. Then we build the architecture, and we look at the current system that we'd like to procure. In this case, would be the electronic medical record system. And we look at the available system in the market. We have to change the architecture, change the requirement, look at the systems to fit them together. Finally, we got a system that fits within this architecture. Then we look at the current system in the organization. S1, S2, S3 are the current system. And we have the electronic health record. We need to get these systems fit within the architecture and follow the standards of the electronic health record. We found that System 1 and System 3 will fit nicely within the architecture. System 2 is closed system. It's obsolete, will not fit within this architecture. It might be considered to be replaced in the near future. For the electronic optometric medical record, the guidelines to have a successful implementation. These are key factors within the School of Optometry and any other similar healthcare organization. In the beginning, we need to get general consensus within the organization that we need electronic optometric medical record system. Meet with key people in the organization, determine their interest, the challenges that they might see related to the electronic systems, and define their willingness to move towards a paperless record. Very important guideline, the championship. And in a recent research paper, defined the success of electronic medical record implementation through the clinician involvement and clinician championship and the top management support. Those are the key factors for successful implementation. Project management to oversee the whole process from the beginning to the end. Deal with the software vendor, establish the plan, get the requirements, and also the expertise. We need health informatics. By health informatics, I mean the applied information, applied computer science information in a healthcare organization to solve a particular problem. And technical expertise as well is very important. Also, the organization requirements need to be defined in the early stages, and the requirement must be realistic and don't fulfill everyone's dreams. All the issues related to the electronic or the medical system must be discussed, whether to buy the system or to build it in-house, which system to choose, have a selection and evaluation methodology, have a plan, and also get the end user commitment, and they also must be or should be motivated and dedicated and invest some time to learn the new technology. The implementation plan for the electronic optometric medical record system must address all the issues related to the clinical workflow in all specialty clinics, all the hardware selection, software configuration, backup security issues. Training is a very important issue. How we will enter the old data into the system, how we would maintain the system, and how we do the testing and improvement in the future. So our experience was this, that we did all the work. We have been through all this process, step by step, and we chose the system that will meet our requirements to achieve a paperless record. The system is based on the school clinical procedures, and we work closely with the vendors to fill the gap if any gaps appear. And the vendors have been in the market for more than 20 years, specializing in developing electronic medical record systems. This is just an example of the Big Bang implementation. I mean by Big Bang is we're going live tomorrow. This is a real life example and happened in a similar healthcare organization in Optometry, United States. They got the system, like they said that we got a system that have everything, fulfill everyone's dreams. We have everything in place, software, hardware, tablet, wireless, and tomorrow we'll go live. This is very difficult. And now they rolled back to paper because they couldn't continue using the system because they went without a definite plan. In our case, we will be using the phased implementation plan. Start by the pre-clinic. By pre-clinic, I mean the students learning the clinical techniques in first year will start learning the system as well. By the time they get into third year and fourth year, they will be mastering the system, know how to use the system. The system will be shaked out in the school. We know that the system works well. We know that everything is in place. The user get trained on the system. And then we go to the second phase would be related to the pediatric clinic, another phase of implementation. One big clinic, the ocular health and primary care, I said that the cognitive load is a little bit high because there are many users, many patients will be in this clinic. And then we'll go to the contact lens clinic and finally like BV, binocular vision and low vision clinic. There are several areas of research that need to be investigated in depth, organizational issue, sociological aspects related to the optometric medical record, the impact of the system on the workflow and the impact on research and teaching. We believe that these aspects are very vital and need to be searched in more depth. Finally, I would like to acknowledge and thank all these people. Dominic Covey for his guidance and support in my framework. Dr. Boubier, Dr. Simpson, Gary Marks, who gave me the opportunity to work on this project. Debbie Jones for her leadership and championship role in this project. And all the clinic heads and that they give time and feedback and comment on the system. And all the staff members that worked with me as well, and some of the students that worked with me on this project, they really were great. Here is a time for the system demo. I'll show you how the system will look like. By the way, the system can be connected to the school right now through the wireless. It can be accessed. Here I'm trying to find a patient with last name, this one. I get the name right away. By double click, I get the patient file. This is the patient file in my hand now. Now any person access the system can have the same view right now. This is how the information is organized through these tabs. These tabs based on everyone preference. This is just a glance on what is in the file. Can give you information about, eye care, chronic health problem. This patient has astigmatism. We can see when this patient came to the clinic. Came on November 1st, November 2nd, November 6th. We can look at the other information, the results here, can compare it. This is handwriting, by the way. You can do it by hand to do any drawing or any handwriting. Here you can see all the previous eye exam. I would like to see the last one. The patient came on November 6th, how it looked like. This is the information, as you mentioned, in a form format. I can do it in a paper format or a preview format. This is a paper record for the patient. Can go back and forth and see the information of the last record. Not only that, I can compare the information for the patient. For example, I would like to know the keratometry reading for this particular patient over time. I can see the results right away, which cannot be done on paper. You can't compare the information on different appointments unless you get all the papers, get through them, and put them beside each other. Now I can see the reading here on November 1st, November 2nd, and November 6th. Not only that, I can get all the information in a comparison format. So I can see here the reason for visit. Patient came over time. This is the habitual glasses, the reading on November 1st, November 6th, November. I can see the acuity over time. I can compare diagrams and pictures over time. Not only that, I can do data analysis. I can find out how many patients have glaucoma by just clicking on one button. Give me the number of patients or who have glaucoma. How many patients over the age of 50 who have glaucoma and are diabetic? How many patients using certain type of contact lenses or certain type of eyeglasses? This can be done instantly and the system can be used by different people in the same time. Everyone can access the same information in the same time. Give you a quick overview here. If I wanted to start a new exam, here the students using the form or using the eye exam. If the supervisor logging into the system from any remote location or in any other location in the organization can see the same information instantly. So I choose the provider. I select the reason why the patient is here. Then I select one template. I call it primary care full exam. These templates are designed and built by the end user. So the user can put any questions here and design it any way they want. So everyone can have his own set of questions. By clicking on the right-hand side, the information will go to the left-hand side. I can click here and make the page bigger. Ask the patient, do you have glare? No. Do you have diplopia? No. Do you have this? No. Do you have headache? Yes, I do. So how many times you get headache? Frequent? Maybe 2 times per week? And so on. So the information can be captured this way. This is the subjective part of the eye exam. Then we go to the objective part of the eye exam where all the clinical procedures are done. Check the patient acuity. I can get the information. Write it this way. Or to make it easy, we have kind of normal values that we set it ahead of time. So we can click on this button here. It will write all the normal values in all the fields here. Then if we have any change, we can change it after that. It asked me if I want to override the data with the normal values. Yes. So the values is written here. If I have any change, I just go change one field. With each procedure has a method that is performed with. Here, instead of choosing the method one by one, I click on one button for default methods. It will write all the default methods for me. I don't have to write every single one. Just put for the BD, I click here. This is a bar where it gives me the lower value and the maximum value. By moving the bar left and right, I can put in the value. By clicking on the right, on the OS value, I can write the value and the OU will be calculated automatically. The same thing will happen on the near. The push-up amplitude, I can put the numbers here in diopter and it will be translated into centimeter. At this point of time, I just want to save the file. I want to see or review it on paper, how it looked like. This is what I just entered now. and the supervisor can view the information instantly. They can see this picture. They can, through the instant messages here, they can send an advice to the student or perform this test and they will be downstairs in 5 minutes until you finish. Or you done something wrong, redo this test. Here I can use the handwriting to draw, do this by hand, or choose another color. Write anything. See how it translated this from my handwriting and the, sorry? Yeah. Or I can write on the screen itself. Yeah, here, comment. And for a statement related to this picture, I can have a preset information that is already in the system, or I can write anything, any comment. Once I close this test, the bottom will be red, meaning that the test has been performed. I can go on and on the same way. Go to page 3 or page 4 based on this is just a quick overview of how the system look like. I'd like to thank you very much, and if any question.
Thank you very much. So questions, if you'd be patient, I'll get to the microphone to you if you have comments or questions.
Maher, the drawing and the tablet-y stuff is cool, but I was wondering about, and I think it perhaps relates to a question earlier about the acquisition of the huge amounts of digital data that exist on sort of standalone machines, some of which are networked, some of which are not.
Yeah.
A whole lot of that stuff could just be captured by a digital picture. How long is it going to take for that to be implemented? Is it implementable? And then I had another question about, so you've decided on a vendor. How does that relate to the province's electronic health record, and how is that going to be put together?
For the instrument integration, it is possible to have the data comes directly from the instrument to the system. Visual field automation, like when I click here, it's under construction. So the information can be captured from one instrument to the system. It is not an easy task to be done, but it takes over some time because the instruments are different instruments from different vendors. Some vendors are, willing to provide the interface for their instruments. Some will not. We're trying our best to get all the instruments implemented with the system. In regards of the second question for the electronic health record, we are following the outlines and the guidelines of the Canada Health Infoway, and we are following the standards. So the system is based on HL7, which is the messaging protocol that is already implemented in the system. Once it is required from us to provide information from our system locally to other system, it will be done. It will be established.
Questions or comments? One of the questions I have is, you had a particular, between your Big Bang and then your phased approach, you had a particular sequence which seems somewhat arbitrary. What caused you to choose that sequence of particular events? I think it was on page 40.
This one here?
Yeah. What caused that particular sequence?
As I mentioned, that the first phase, if I start the Big Bang, that's going to be the big issue. I started with the pre-clinic. Pre-clinic is the environment where the students in their first year in the School of Optometry learn how to do the clinical examination and how they record it on paper. In this time, they will learn how to do it and how to record it on the computer. This is because the system is not in its final state yet. The system is still under development, and it's under beta testing. It's very hard to implement the system into the clinic right away. So I chose to do the pre-clinic first. By the time the student go to second year, they will be learning more and doing more. Third year, they come to the actual clinic where they see patients. They know how to master, how to use the system. All the clinicians in the school will have the chance to use the system and learn how to use it. The system will be shaped and tested and evaluated and improved over time. By the time we come to the actual clinic, we choose pediatric clinic, which is deal with a small number of patients, so the work processes will not be disturbed that much. On the other hand, for a clinic like primary care and ocular health, where they see a lot of patients and many clinicians working there, so we're expecting that the cognitive load for the system will be a little bit higher. But over time, it will be lower when we come to another clinic, that contact lens and the other specialty clinics, binocular vision and low vision.
Interesting. Grant?
Thank you. One of the problems that we have now, obviously, is there's a fair divergence in each of the clinics in what their records look like in terms of actually recording what is essentially the same information in different clinics. Everyone sort of has their own leader, and they set up their own record. Yeah. Is there any virtue in trying to, while you're making the change or introducing the electronic record, to try to start at the other end and try to get people to use similar paper records? Like, do you think there would be any virtue in that, or would that help the process?
That's a very good question. As I mentioned earlier, that how the paper record come in different format. If you go to any optometric clinic in the private market, everyone will have his own. There is no agreement on one standard format. And the electronic medical record system promises to do that. And we would like to get a consensus among the clinicians in the School of Optometry to agree on a standard format. In the same time, the system will provide the flexibility with every single user to do any additional thing. As in the subjective area, the clinician can design or can have their own set of questions here. Like if I pick here any name, any provider, I will see different templates. So each template is designed based on each one preference. Something else, like this is the standard format of the form. Each user can also add additional information. Can write a note, free text area to write any additional note that is related to the a particular patient. Can write anything here. Once I save it, it's indicating that there is something in this note. Did I answer your question?
Yes, I think.
Thanks.
It seems to me that one of the beauties of an electronic record is that you don't have to have everybody using the same form. If this information is somehow stored in a database behind everything, and I would think that every clinic, even within the one school, could enter data using a completely different form. If you don't like sort of the acuities in the lower left because you always put that in the upper right, I don't see why you would want to insist that everybody use the same looking form. Views for data presentation, sure, and even for data entry, as long as there's an automatic way to convert from one of the data entry forms to the other data entry form, then I would think that would be the right way to do it, rather than one of the reasons that people don't accept systems is because it forces them to use different kinds of forms. And I think that would be a mistake, I think, trying to teach people to use different records first.
Yeah, it's a very interesting point. As I mentioned, that the flexibility here in the subjective area, it will be in the objective area, in the form. The system will allow the user, that's, in later stages, the user can customize the form by himself, can change the layout, can organize the information any way they want. They can put the acuity in the second page. They can put Amazon grid in the last page. And they can have their own data input. They can design it differently. This capability will be provided in the system in the future.
And still, it would seem that, and still, if one doctor enters the data or one student enters the data in one particular format, there's no reason why it couldn't be presented to a different person in a different clinic in the format that that person is willing to see.
Exactly.
And in fact, some of these things, if there are measurements that are done repeatedly,
Yeah.
It certainly could automatically carry forward. As the first time it's done, it could be carried forward to the other form,
Yeah.
and then perhaps overwritten in the other form if that person says, no, I've got to do it again because that wasn't right, or I just don't believe it anyway because I always have to do it again.
Exactly. The main challenges in this regard for the software vendor is that the requirements is always change. If you ask the end users, they will tell something today and will change it tomorrow. So it's very hard to get the agreement on the requirements. So the vendor will do it today based on the user requirement, and tomorrow another user will change the requirement. So we have to go with one standard format. We have to agree on that, and we can reevaluate the system over time. Get user to agree on a particular requirement, and we can add it to the system in the future.
I think the point that Frank is making is that it's a shame that, in fact, the system isn't established, that someone cannot reformat, because as long as everyone agrees on the data element name and the values and the standards for any measurements, then, in fact, being able to rearrange the screen gives a high degree of variability for allowing that easy adoption. While if you have everybody converging on a standard format, you're actually forcing people, sort of press ganging them into a particular way. Mm-hmm. So it may not be possible with this system, but I think the point's well taken. I don't know if I've said it well enough, but also the reports is that if you like your report this way and another one likes it upside down compared to that,
sure.
The ability to flexibly do that is I think, critical in the long term.
Sure.
I guess my question is that you're training students here, and if you have constantly changing forms that students are using, is there a greater probability of error in terms of data entry? And two, will it take them more time because they have to hunt and search for every different form where to do the data entry?
That's why we started with the pre-clinic with the students to have one system, and the pre-clinic is just the beginning. It's not the end. We just teach the students how to use the system in a standard format. As you mentioned, if we give them the options to use different format, that will be confusing for the students. As in the same thing with the paper record, they use one format, they don't change it.
This will probably be a rambling thing because it sort of relates to the previous stuff and something else. But I mean, it strikes me that you have all the information you need to customize this form to a user, because someone's going to be logged on to look at this information, and if they prefer when they're in pediatrics to look at a form in a particular way, that could just as easily be in the same way as that subjective pediatric examination has a macro that defines what the contents are. You probably could have something sitting in the background that if it is Bobier and he's in peds, that this thing comes out looking like that. It doesn't seem like that would be a hugely difficult thing, and I like the idea of it being customized for users, because that would make it more likely to be adopted by everybody.
Yeah.
Which segues to the next question of, do you have a plan for the sociological components of the implementation. I like the idea of doing it in the preclinic and then peds and sort of ramping up. What that does is that buys you time, but I still don't know how you go from the gamut of early adopters to, I don't know, Luddites, people who just never use stuff, who don't want to change anything. And you know, the idea, for example, of customizing this for an individual, it's just such a cool idea because it makes it look like it's for them. Each individual, the thing is being done for them. And I think that that's a really great sort of sociological lever to say, no, you don't have to change anything. What do you want? Tell us what you want. We'll make it for you. So do you have a sense of how you're going to adopt it? Again,
Sure.
You've got time there,
Yeah.
but I don't know how you're going to train people.
Now the system in its early stage, this is the beginning of the system. This is not the final system yet. And all the issues related to customizing or changing or evolving the system will be discussed with the clinic heads in the school. And we have to get to an agreement. Yes, this is what we really want, and this can be done. Technologically, it can be done. It can.
I think that sounds great, and there's not a criticism, but you've spoken to the heads of those clinics, and you know that that's a diverse group, as it would be a diverse group if we sat down and said, okay, how do we best design these forms? Never mind people who are familiar with them, but you know, I want it to be like this, and I don't want it. I want it all to be keyboard. I want it all to be mouse. No, I want it all to be tablet. I mean, I think that the idea of being able to derive consensus in that list of people who you thanked is pretty scary, and that's not the people who are going to be the users, right? Then you have to convince the users, and I don't know what data there are on that. I don't know what processes there are to you know, those people who need to be massaged, you need to massage them, and those people who need to be beaten, you need to beat them. How do you? I guess the South African in me coming out. How do you?
That's
always
not my
worry
role.
about that bad conditioning.
That is not my role. Yeah.
I mean, I think I've always worried about that. I mean, that's been the sort of the thing that I'm worried about the most is not the software. I think that we're going to be able to make the software any way we like. We're going to be able to convince the vendor that it's going to be useful for them to have it flexible and for us to be able to go back and for a reasonable amount of time. But then eventually you're going to have to convince us, and I worry about what is the strategy for dealing with us, other than time.
Yeah, I would say that there is no system in the market right now that can fulfill everyone's dream. And if we wait until we get what we're looking for, we will be waiting forever. So we need a system right now, and we have to put some sacrifices. Like, you know, you will not get all what you're looking for. Just to get 70%, you should be happy. And the other 30% will be evolved over time. You will get it.
But the question is not the technology. Let's say the technology is 100%.
Yeah.
The fact is that you need a strategy for introducing people that run from the people who take any system to the people who won't take any system. And what is that strategy? Have you given that thought about how you're going to go about doing it? There's a lot in the literature about that, but where are you on that with strategy?
I start with the preclinic instructors. So they learn the system with the students, and they get experience in using the system. The preclinic will be the environment for training the instructors in the School of Optometry as well. Every clinician will have access to the system from his office, so he can play with the system, can use it. The training will be one-on-one, like I will be training every person in the school how to use the system. Group training. As I mentioned, like, you know, over time, the system will be accepted and implemented from one clinic to the other.
I just want to comment that a couple of weeks ago we had Diane Beattie here to talk from the London hospitals, and she undertook a project, or their hospitals took a project in which to spread the use of diagnostic imaging systems throughout those hospitals. And most of her talk was not about technology. It was about the process of implementing the technology throughout those many different hospitals. And I think there are some really interesting techniques that they incorporated there. It was very much a team approach that passed it on to the next team. And so there was a constant hand-holding process that went from team to team, and it was like passing the torch. But the people that were the last to be involved in implementation were very much closely aligned with the next group to be implemented. And so they passed on those best practices as they went through. It was a fascinating talk, and I think that might be a place to look for some of the strategies that you might want to incorporate.
Sure.
My comment was that early retirement is yet another solution. We know who we retire quickly here. I want to comment on that because if you look at the literature, there are, in fact, many strategies. We were talking about implementation and training, but the issue is how do you get one person who may be more resistant than another person to adopt the technology? And clearly you don't have infinite flexibility in changing it from person to person. One of the strategies is how you create that team, who you get, like an opinion leader, for example, on the team, who then convinces his or her peers. Those kinds of sociological approaches, including having team rewards. They did a lot at Mbiti's thing about when the team had a success, they had a party. There was a good feeling about getting. I mean, you're in some sense, and you always do this, you're manipulating the people, but that manipulation is towards a good end. And the good end is that gradually people adopt it. But training won't do it. I think these interventions may have a greater potential. I want to ask you a quick question or two. One is about privacy. Where do optometric records fit with regard to the privacy legislation, like PHIPAA, for example, or other types?
It's HIPAA. It's related to the United States, I believe.
No, the Canadian.
The Canadian one. It is following the privacy, and it follows all the rules for the College of Optometry, related to the electronic medical record system.
So those names we saw were not real patient names.
No.
We actually had an occurrence in the United States many years ago where, remember, the military was in the audience and someone showed actual patient records and he shut down the talk. Canceled the talk. The other aspect is research. You talked about research in this. What kinds of thought has been given to the potential of a system like this for research? And you guys may want to answer that as well. But where is the research element in this in terms of the data? As
I mentioned, I invite all the researchers in the School of Optometry or anywhere else to work with me in this regard, to do in-depth research to evaluate the system, how it is different, how the system improved the work practice, how did it affect the research and teaching. I'm willing for any projects to work on this research in depth.
Okay. There can be research, obviously, on the workflow and its improvement evaluation of the system. That's important. But what about research that uses the data of the system? In other words, looking across the database and saying, seeing unusual patterns or identifying trends, for example, and those kinds of things. Has there been any discussion about that so far? Or? I don't know. Graham, do you have any?
I think it ends up being probably a lot of demographics around our own specific clinic population, but I think also there's an opportunity for biometric research. Like there are lesser research topics that you really wouldn't sort of set out to investigate unless you had this kind of easy access to the data that you use. And so, for example, like in terms of biometrics, I know, for example, in terms of forensics, the frequency distribution of sort of normal presentations is something that really is extremely important, and there are no data about that. Something like the distance between your eyes, for example, there's all kinds of things like that where this would give you a lot of sort of biometric data that would be useful in a number of different ways, but it is limited because we do have such a unique clinic population. You couldn't extrapolate from these data to the general population. So, there's a lot of potential, but a lot of disadvantage. I don't know if it's working.
I think the use of the data is a very exciting part of convincing people to implement it. And I think that you gave a very straightforward example of how many people who have glaucoma have this particular thing, and that power you just can't do. We just don't have it in paper records. It's such a tedious thing to go and get even the most basic kind of epidemiological thing if we think of our databases for being able to provide us with some kind of epidemiological information. But I think that the critical thing which we haven't spoken about here is the power of the application is in searching the database. And if the database starts today and goes forward, it's going to take us 20 years before we have a database. And so we need to have another way of putting the hundreds of thousands of records which we have in that huge room onto the system, or at least components of it in some kind of way. And I'm not sure that we've sort of specifically planned that. But for it to be used for research now, just for big numbers, it's not going to be of any value immediately. But I think that there are a huge number of us that are very excited for all sorts of, a bunch of diverse reasons, never mind biometric stuff. There's sociological stuff, who are the patients that come to our clinic. There are things that will drive economics, costing. It just provides us with a huge amount of power. But I worry about what that database is.
One of the features that goes forward is clinical trials, and I know you're planning. This could become the base for really good clinical trial management and capturing of the data and so on. So that might give, if not large amounts of data, at least a high-quality study type base.
Going back to the design of the record, last week we had a short little talk by Laura Varpio, and she's very much involved in a project down at one of the Toronto hospitals in the design of their electronic health record. She always mentions that there's the two-part of designing the record. There's the textual part, but then there's also the visual visualness of the record itself. So she's done both sides of that. And I don't know whether that's been considered in the design of your particular layout, but she might be an interesting one to be an associated team member, for example, as you go forward.
It has been considered in the system design and development. Trevor, remember the old system, how it was look like? The system has been evolved over time from an old design that was kind of overwhelming, that when the users see the system, oh, that's too much. And now all the users or the people who looked at the system in the school agree on that the system is simple, it's similar to what we have, it's easy to use, and so on. But the old system was so difficult and overwhelming to use.
It's interesting is that her area of interest is rhetoric, and they're talking now about visual rhetoric. In other words, you've gotten a sense of that, your crowded, loud form compared to a more friendly form. There is a rhetoric to presentation as well. And that whole usability area of people's willingness to use certain kinds of environments are another area of interest. So might be some opportunities between the usability people and so on. Well, Maher, thank you very much.
Very welcome.